All right, welcome back everybody. So in this video, which is our final video of the series, we are now going to talk about a renal tubular acidosis type 4. This type of renal tubular acidosis is sometimes also called hyperkalemic renal tubular acidosis. And notice one of the points that I make here that I list as high yield is that this is associated with high levels of potassium. The reason this is so high yield is because it differs from the other types of renal tubular acidosis that we previously talked about. Type 1 and type 2 are going to present with hypokalemia, which you've talked about the mechanisms as to why that is, but here it's the only one that presents with hyperkalemia. So if you're given a question stem about a renal tubular acidosis and you look at the lab values and you see the potassium is higher or outside of the normal range, well, right away you are going to know this is a type 4 renal tubular acidosis. So let's talk about what causes this process. So the pathophysiology says that a decreased level of aldosterone or an increase in aldosterone resistance is going to lead to hyperkalemia. This ultimately results in decreased NH3 production in the PCT, decreased NH4 excretion from the body, and again, all of our RTAs are going to be a normal anion gap metabolic acidosis. So let's talk about this step by step. Remember, what is the goal of aldosterone secretion? That's right. It's when our body senses low volume status, it will activate the RAS system, releasing aldosterone. And we know that an elevated level of aldosterone would ultimately lead to increased sodium reabsorption and thus decreased potassium and hydrogen in the body. So now let's think about if our body does the opposite, or if we have decreased level of aldosterone or aldosterone resistance, how is that going to change the sodium, potassium, and hydrogen? So if now we say we have decreased aldosterone, well, that's going to lead to decreased sodium and ultimately increased potassium and hydrogen ions. And this is why we get hyperkalemia, because we're going to get the opposite effect of if we had too much aldosterone. Too little aldosterone is going to decrease sodium, decrease potassium secretion, and decrease hydrogen secretion as well. So now we're at the point where we have this elevated level of potassium. Well, now our next point is saying that we have a decreased NH3 production in the PCT, and we are attributing that to elevated levels of potassium. So if we draw our attention to the PCT over here, we see that elevated levels of potassium inhibit the production of NH3. This ultimately leads to less NH3 being secreted into the tubules. And then if we follow our arrow down distally into some of the distal portions of the nephron, we would expect to also see that lower level of NH3 because we produce less of it early on in the nephron. So then how does this cause a decreased NH4 excretion from the body? Well, think about it. If we get lower levels of NH3 distally in the tubules, where we would normally have our hydrogen ions being pumped into the tubule through an ATPase, well, even if those hydrogen ions are still being pumped through the tubule, if there is less NH3 for it to bind to, well, overall that is going to cause a decrease in NH4 being produced and ultimately excreted from the body. So again, just to reiterate, proximally an elevated level of potassium inhibits our ability to form NH3. Less NH3 is sent distally in the nephron, and so at the areas where hydrogen ions are pumped into the nephron and would typically bind to form NH4, well, now if we have less NH3 available, thus there's less to bind to, that results in an overall decrease in NH4 production and excretion from the body. So again, to reiterate, elevated levels of potassium result in less NH3 production, ultimately leading to less NH4 excretion from the body. Note that the urine pH is going to be less than 5.5 because we don't have any blockage in our hydrogen proton secretion, and thus we're able to maintain a relatively acidic environment in the tubules and in the urine. Do you remember which RTA we needed to associate with elevated urinary pH because it has a high risk for nephrolithiasis? That's right, our RTA type 1. Remember, because in RTA type 1, we have a problem with hydrogen proton secretion into the tubules, and thus we cannot acidify our urine, ultimately predisposing us to kidney stones. Next, let's look at some of the causes that can cause this. And this should make sense to you at this point, right? We said that low levels of aldosterone is one of the primary things that can cause a type 4 RTA. This can present as hyporenemic hypoaldosteronism. And what this means is that any process that decreases our secretion of renin is ultimately going to decrease our secretion of aldosterone. Why? Because renin is a step earlier on in the pathway. Remember, our kidneys go through this process where they sense low volume status, they secrete renin. Ultimately, renin converts angiotensinogen into angiotensin 1. Angiotensin 1 is then converted to angiotensin 2 by the ACE enzyme, and we know that angiotensin 2 has many different effects on the body. One of the primary ones is increasing the secretion of aldosterone. There are a variety of different things that can cause this presentation, but really I just want you to memorize the kind of general principle in the overarching theme here, which is that anything that decreases our ability to secrete renin is ultimately going to decrease our ability to secrete aldosterone. Another way that we can get decreased aldosterone secretion is through primary adrenal insufficiency, sometimes also called Addison's disease. In primary adrenal insufficiency, we have a problem with the adrenal glands, and thus our ability to release or secrete aldosterone is going to be limited, which can ultimately lead to a type 4 RTA. Our next category includes anything that can cause aldosterone resistance. So potassium-sparing diuretics are going to be one of our primary causes here, right? Because recall that potassium-sparing diuretics are aldosterone antagonists in the collecting tubule. And an aldosterone antagonist is going to give us a very similar presentation to a type 4 RTA, in that if we inhibit aldosterone's ability to act at the level of the cell, it's going to block its typical effects of reabsorbing sodium at the expense of hydrogen and potassium. A medication that might be less commonly asked about is trimethoprim sulfamethoxazole, and this can cause a similar presentation as well. That is a presentation of RTA type 4 and hyperkalemia, because this medication can block amiloride-sensitive sodium channels in the distal nephron. So this is going to present with a similar presentation. If we're blocking aldosterone or if we're blocking the sodium channels, we're going to get a similar finding in a patient. Our management options for a patient with a type 4 RTA would include things like fludrocortisone or furosemide. Recall that fludrocortisone is a synthetic mineralocorticoid that can mimic aldosterone's activity, and furosemide can be used to primarily treat the hyperkalemia in the patient. Do you remember how furosemide works? That's right. It's an NKCC inhibitor, which means that it blocks the reabsorption of potassium, and thus it's sometimes called a potassium-wasting diuretic. And treating the high potassium levels is one of the primary things that we need to do for these patients, because we know that super high levels of potassium or super low levels of potassium can cause very significant complications for the patient. And so this is one of the primary things that we work to do, is to restore a typical potassium balance. And we can do this by giving a medication that causes more offloading or more excretion of potassium ions. And to finish this video, I want to revisit our memory aid. Do you remember what we used to remember the difference between type 1, type 2, and type 4? We said type 1 involves hydrogen protons because there's only one letter for H, and it's also the first element in a periodic table. We said that type 2 involves bicarbonate. Bi is a root word meaning 2. And for type 4, which is this video, we said it involves more potassium. And this is why it's called a hyperkalemic RTA. So hopefully that's helpful for a memory aid for you so that you can keep them straight in your mind and have an easier time answering questions. All right, that's all I have for this one. Great job, everybody. That concludes our chapter for acid-base physiology. This is a really dense and complicated chapter, so feel free to go back and rewatch some of the videos, pause, think about these things, how you might apply them to questions. And I think the really great thing about physiology, there's so much that we need to memorize early on our medical education. There's so many things that are new, so many terms, but physiology is really about an understanding. It's less about memorization than maybe some of the pathology that we need to know. And so with physiology, if you take the time now, if you take the time up front and you invest and really understand the physiology, you can apply it to so many different concepts in so many different ways that you're going to be an excellent test taker when the day comes. Now, with that said, I will see you all in the next chapter.